Dear students, today I'll try to take up complications of chronic suppurative otitis media. Chronic suppurative otitis media is a disease which is mostly neglected by the patients because of obvious reasons. India being a developing country, because of the poverty, illiteracy, and ignorance, and various superstitions prevailing in the society, there is no wonder that disease like chronic suppurative otitis media are neglected. If it is a chronic suppurative otitis media of tubotympanic variety, it's okay. But if you neglect chronic suppurative otitis media of atticoantral variety, which is characterized by cholesteatoma, which has got very characteristic feature of destroying bone, the disease can have a ready access into the intracranium. So complications are very much known to occur in case of chronic suppurative otitis media of atticoantral variety. That doesn't mean the other variety, tubotympanic type, is 100% safe. It's not 100% safe. Now, what are the influencing factors which produce these complications? Thank God, because of the modern antibiotics and modern awareness, because of undergraduate teaching, we always say there is some sort of knowledge and the complications have decreased dramatically. But still, we have to keep this particular aspect in mind and be ready to deal with these things. What are the influencing factors? First and foremost is age. That is, extremes of age in children as well as in older people. During this period of life, there will be generalized body resistance, which is slightly at a lower level. So they are all prone for the infections, they are prone for the complications. Apart from that, the virulence of the organism, the Streptococcus pneumoniae or even Pseudomonas, if the organism is very virulent, the host defense mechanism is not at a equal level to defend it, the patient will automatically develop complications. In certain individuals who are having uncontrolled diabetes, uncontrolled hypertension, or people on long-term steroid therapy, or people on immunosuppressants, say after a kidney transplant, these people are very prone to develop complications of chronic suppurative otitis media. And in certain individuals, the complications are more common, particularly in patients having certain preformed pathways. What are those preformed pathways? Number one is fractures. If there is a fractured temporal bone, whether it is longitudinal fracture or transverse fracture, they are hard to unite like long bones. Long bones, if they get fractured, they automatically, the calcification forms, callus forms, and automatically they unite. It's not case with the flat bones. So it, at the most, it heals by fibrous tissue. That means the fracture line stays as it is. So through these fracture lines, the infection can access the intracranial. In the same way, in certain individuals, there will be dehiscence of a bone, especially dehiscence of the fallopian canal, and facial nerve will be bare. In the same way, there may be dehiscence of the floor of the tympanic cavity, producing naked appearance of the jugular bulb. So during these dehiscences also, infection can enter and produce complications. In the same way, surgery. Suppose in case of stapedectomy, what we do, we make a perforation in the foot plate. In case of stapedotomy, we make a perforation in the foot plate and introduce the processes. In case of stapedotomy, we remove part of the posterior half of the foot plate of stapes and introduce the processes. Whatever it is, since we are opening the inner ear and apply a process, that means there is an access into the inner ear. When if there is infection in the middle ear, it can extend the inner ear. In the same way, fistula. Say for instance, in case of chronic suppurative aortic stenosis with cholesteatoma, there is a fistula over the lateral semicircular canal, which is very, very common. Less common is fistula over the promontory. Once there is a fistula, infection can readily enter and produce complications. And other condition is called large vestibular aqueduct. Large vestibular aqueduct is a congenital condition associated with Mondini deformity. What is Mondini deformity? Mondini deformity is the cochlea not having full 2.5 turns, only 1.5 turn, plus large ventricular aqueduct. See this is cochlea, this is the membranous labyrinth, and the endolymphatic sac should come here like this and like a thin fan-shaped structure. But see this, it is grossly enlarged because of the large vestibular aqueduct. And this condition is prone to produce intrarenal complications. And last but not the least, the cholesteatoma, which is notorious in producing complications, either directly eroding the tegmen or by producing the fistula or the promontory or the lateral semicircular canal. So what are the complications we expect? The infection, it extends into the extradural space, that is just above the dura. That means above the tegmen, below the dura, in between dura and the tegmen, that is extradural space. There may be collection of pus in the extradural space. Or it may be underneath the dura, that is subdural space, that is subdural abscess. Or it may be a cerebellar abscess, or it may be a cerebral abscess or temporal lobe abscess. Usually the part of the cerebrum that is near to the ear is temporal lobe, that is cerebellar abscess. Apart from meningitis can occur. And the lateral sinus, which is very closely attached to the posterior aspect of the mastoid bone, it may get thrombosed, and patient may have coalescent mastoiditis, and patient may have facial paralysis or labyrinthitis. So by and large, we divide these complications into extracranial complications and intracranial complications. Now, once again, let us see how the infection spreads. Medially, if the infection spreads to the labyrinth through round window and over window, and also lateral semicircular canal with a fistula, it may produce meningitis. And if the infection extends superiorly, again into the middle cranial fossa, an abscess can occur, either cerebral abscess, the temporal lobe abscess. Occasionally, it may also lead to meningitis. If the infection spreads posteriorly into posterior cranial fossa, there may be an extradural abscess. This abscess, extradural abscess, will be generally in between the sigmoid sinus and the bone. That means overlying the sigmoid sinus. You may find extradural abscess. Or patient may also develop lateral sinus thrombosis. Or patient may also develop what is known as posterior fossa meningitis or a cerebral abscess. And if the infection extends inferiorly, then also the complication occurs, that is called jugular vein thrombosis. What is the structure that is closely related to the inferior aspect of the tympanic cavity? Interjugular vein. This is the lateral sinus which extends anteriorly and it forms a jugular bulb which is closely related to the inferior wall of the tympanic cavity, which continues downwards as interjugular vein. So patient may develop thrombosis of the interjugular vein. Coming to the extracranial abscess complications, first and foremost is the mastoiditis, second is vitreccitis, third is facial paralysis, and fourth is labyrinthitis. These are the common extracranial complications we come across as a result of the chronic suppurative otitis media. What are the intracranial complications? Extradural abscess, subdural abscess, meningitis, brain abscess, and lateral sinus thrombosis, otitic hydrocephalus. First and foremost is mastoiditis. Mastoiditis, that is acute mastoiditis, it is characterized by pain in the ear. Generally, acute suppurative otitis media will be resulting because of the infection of the middle ear cavity, characterized by pain in the ear and light drop of hearing and fever, malaise, and so on. And slowly the infection, it increases, exudate increases in quantity, tympanic membrane will bulge, and then we will perforation of the tympanic membrane, resulting in the discharge appearing, pain getting relieved totally. Almost totally pain gets relieved. But if the discharging pus is still loculated in the middle ear cavity, there is no other way except extending backwards through adductus ad antrum into the mastoid cavity. So, if the tympanic membrane gets perforated and drains all the pus, patient will end up in a resolution of the otitis media. Of course, there will be a perforation. The perforation is very small, it will heal subsequently. If the perforation is very big, there will be a permanent perforation syndrome which needs to be addressed at a later date. But as far as a part and parcel of the acute suppurative otitis media, this mastoiditis can develop. Now, how do we recognize mastoiditis? Mastoiditis we can recognize by means of the persisting pain in the ear, and you can find tenderness of the mastoid process. Where do you palpate for the tenderness of the mastoid process? There is what is known as 3-point tenderness. That is, one finger, your your ring finger in the Simba concha, which is closely, which corresponds to the mastoidantrum. The second index finger just behind the mastoid process, just behind the mastoid bone, and the thumb or the tip of the mastoid. This is called 3-point tenderness. This 3-point tenderness is characteristic feature of acute mastoiditis. Apart from that, if you do a Junifor test, there will be contractile deafness generally, and there may be other features like fever, and then there may be a slight upper respiratory catarrh also. All these things, they point out towards diagnosis of mastoiditis. If you look at the tympanic membrane will be still congested, and there may be a perforation, there may not be a perforation. But presence of tenderness or the mastoid process is the diagnostic sign of mastoiditis. Now, suppose mastoiditis is neglected, it can give rise to various abscesses in relation to the ear. If the infection in the mastoid slowly it destroys the outer wall of the mastoid, then infection spreads into the subcutaneous space just underneath the skin. That is called subperiosteal mastoid abscess postauricularly. Postauricular abscess in the postauricular region, the subperiosteal abscess in the postauricular region. Now the infection, it can trickle down, extending medially to the mastoid process, and it may extend along the sternocleidomastoid or posterior digastric and can produce an abscess in the neck. This is called Bejol's abscess. The infection can extend anteriorly through the posterior root of zygoma and produce an abscess here in the zygomatic region, that is called zygomatic abscess. If the infection can extend backwards through what is known as canal for mastoid emissary vein, near the canal for mastoid emissary vein, it may produce what is known as a Settle's abscess. That means abscess just behind the mastoid process. And sometimes the abscess can directly open into the external aortic canal, producing drainage through the external aortic canal. That is called Lux abscess. Now, what is actual etiopathogenesis of the mastoiditis? In mastoid, first stage is there will be infection of the mastoid hair cells, and there will be exudate formation. Slowly the exudate increases and it will become pus. That means that is stage of suppuration. From stage of exudate formation to stage of suppuration it comes. And once stage of suppuration comes, there will be what is known as the blood supply to the mastoid process will increase. That is, there will be hyperemia. Once there is hyperemia, it always decalcifies the bone. That is called hyperemic decalcification of the bone. And there will be osteoclastic reabsorption of the bony valves. As a result, the entire mastoid process will become like a bag of pus. As it is already mentioned, there will be pain if patient compliance, and there will be 3-point tenderness. There may be fever which is not responding very easily, and there will be discharge. Once a discharge appears, we must take a swab for culture and sensitivity so that you will know the organisms and the antibiotic to which it will respond. And very occasionally you may find this particular sign, that is sagging of the posterior meatal wall. What is sagging of the posterior meatal wall? Suppose ear canal is like this, and the posterior part will be sagging. That is, it will be hanging down slightly. It's a very important sign. It is because of what is known as periosteitis of the bone of the posterior superior meatus. Posterior superior meatal wall, it is bony posterior superior meatal wall. If it is inflamed, then it produces this sagging. So it is an indication that there is underlying infection inside, which is very active. And if you examine the postauricular region, there will be retroauricular sulcus. That retroauricular sulcus will be obliterated. And needless to say, a patient will be having hard of hearing at various degrees. And you have to do investigations like total count. The total count will be very much increased, and there will be differential count. What will happen differential count? Because of the acute infection, there will be polymorphonuclear leukocytosis. There will be increased ESR, and if you take an X-ray of the mastoids, lateral view or Schiller's view, it is normal mastoids either will be sclerotic or cellular. Normal mastoids. Generally, this mastoiditis occurs in relation to the cellular mastoids only. So the cellular mastoids, because of the presence of pus and coalescent mastoiditis, there will be loss of normal honeycomb appearance of the mastoids. Nowadays, this is the age of imaging. We can directly get a CT scan done. Very clearly, you will see the haziness of the mastoids. Now, culture and sensitivity should be always done to know the organism. Now, what are the differential diagnoses? Every pain in the ear cannot be dubbed as mastoiditis. Most important thing is furunculosis in the ear, which is also very, very painful. I think I have told you in the last class, the clinching point between the diagnosis of furunculosis and the mastoiditis is tragal tenderness. If you apply gentle pressure over the tragus, it will be tender. And sometimes if you pull gently, especially in children, auricle laterally, it will be also painful. And sometimes there may be slight pain just below the external canal in case of furunculosis. And there will be, if you examine the discharge, it will be purulent in case of furunculosis because it is pus. Whereas in case of mastoiditis or in case of otitis media, the pus is mucopurulent. That means there will be mucus element will be there in the discharge. Why? Because the medullary cavity and mastoid cells, they are abundant in mucus glands. So with inflammation, they readily produce lot of mucus. So if you examine the discharge, you will know whether it is from the external canal due to furunculosis or from medullary cavity due to otitis media and mastoiditis. Now, how to examine clinically? If the discharge is profuse and thready, if you try to clear the discharge, it will come out like a thread. That thready discharge is always because of the mucopurulent nature due to medullary infection. Whereas the discharge from the furuncle will be like pus and it is not thready, it is not profuse. And if you examine carefully the tympanic membrane in case of furunculosis, no doubt it will be very, very painful. You take a small size ear speculum and gently try to look into the tympanic membrane. It appears normal. It is not congested. Whereas it will be congested in case of otitis media. If you take an X-ray of the mastoids, when there is a furunculosis, it will be normal. There is no cloudiness like in mastoiditis. Very rarely, an infected sebaceous cyst or an inflamed mastoid lymph node, which occasionally is seen over the tip of the mastoid, may be confused with mastoiditis. Now, how to differentiate between furunculosis and the mastoid abscess? So the final diagnosis, you put a needle. If you put a needle and try to aspirate, if it is furunculosis, immediately below the skin you will encounter pus. But if you have to go down, piercing the periosteum, going almost up to the bone, then if you encounter pus, that it must be mastoiditis, mastoid abscess. Now, how do we treat? Treatment is hospitalize the patient and give him a full course of antibiotic, preferably parenteral, because you have to treat the patient on a war footing. Otherwise, the infection may spread and it produce dangerous complications. So, what antibiotic is preferred? Generally, either third generation cephalosporins or amoxicillin clavulanate. These antibiotics are very effective and they will control infection very readily. And if by the time you receive the specific organism and the specific antibiotic, we can continue if there is no response. And sometimes the acute suppurative arteritis media is so severe and produces mastoiditis that the trypan membrane continues to be congested, continues to be slightly bulging. Then you can do what is known as myringotomy. Myringotomy is different from myringotomy which you do for the serous arteritis media glue here. As I told you in the last class, in case of serous arteritis media, when there is glue inside the medullary cavity, you will make a small incision just in the anteroinferior quadrant and drain the glue out and introduce a small grommet. But here in myringotomy, with respect to the AOM, ASOM and mastoiditis, you have to give a liberal myringotomy incision, a U-shaped incision surrounding the malleus handle. Why? Because the infection, the pus should be totally drained out of the medullary cavity, so that if you give a small incision, the pus will still get loculated inside. So you have to give a liberal U-shaped myringotomy. If patient doesn't respond, then you have to think in terms of cortical mastoidectomy, emergency mastoidectomy. And once again, I tell you, these incidences have become very, very rare now because of the very effective antibiotics we have in the armamentarium. But still, sometimes with patients, because of the following indications, for instance, pain. The pain doesn't subside with antibiotics and routine painkillers. And fever. If the fever doesn't subside and patient continues to have vertigo, in spite of very effective treatment, and patient has a threatened facial paralysis and sagging of the posterior superior meatal wall, as I have told just now. And if there are threatened intracranial complications, then there is no point in waiting. Immediately you have to subject the patient for mastoidectomy, cortical mastoidectomy. What are the various mastoid abscesses we encounter? Already it is mentioned. It is zygomatic abscess in the zygomatic region, and post-auricular abscess in just behind the ear, and Bejoel's abscess in the neck, and Settle's abscess far behind the ear canal, far behind the pinna. Apart from that, patient also may have parapharyngeal and retropharyngeal abscesses. If you see the picture, what is the parapharyngeal space? Para means just by the side of. This is the pharynx. This is the pharyngobasilar fascia, and this is the parotid gland. Just below just in between the parotid. Parotid is covered by what is known as medial parotid fascia, and medial parotid fascia. This is the parotid gland, and this pharyngobasilar fascia. In between these two, we have got this particular space called parapharyngeal space. Parapharyngeal space has got a pre-styloid compartment and a retrostyloid compartment. So this pre-styloid compartment has got only loose areolar tissue. It is in this particular area the pus collects, producing what is known as a parapharyngeal abscess, which is characterized by bulging of the pharynx. Suppose there is a pus here, what happened to the pharynx? It will be bulging medially. So it may also bulge laterally also, producing a swelling in the neck. It may also produce medially also, producing a diffuse swelling in the pharynx. So that is parapharyngeal space. This happens when the infection trickles down from the air cells in the petrous apex. They involve. In the same way, patient also may have a retropharyngeal abscess. That is, once again, this is the retropharyngeal space. This is the body of the vertebra, and these are the colli muscles, and this is the fascia or the colli muscles, and this is the space between the pharynx and the vertebral bodies. That means this area, if it involves, if there is collection of pus inside, it may produce bulging of the posterior pharyngeal wall. That is, it will appear something like this, and patient may have see this. You can see this posterior pharyngeal wall will be bulging anteriorly because of the collection of pus in between the prevertebral fossa fascia and the pharynx. Now, in spite of your best treatment, patient is continuously having some symptom or other. It will not be very acute, but still patient sometimes complains of dull pain, slight fever, and a slight reduction in his hearing. And if you examine the tympanic membrane, still there may be some congestion. And if you examine the mastoid for tenderness, there may be slight tenderness and headache. You have to suspect what is known as masked mastoiditis. This masked mastoiditis is a result of insufficient or ineffective treatment of a mastoid infection by antibiotics. So immediately again the patient has to be hospitalized and give a full course of specific antibiotic for a little long period. If patient doesn't respond, once again you have to consider cortical mastoidectomy, wherein you will find the granulations and pus, everything, very because of the improper, ineffective management of the mastoiditis conservatively. Second complication is petrositis. What is petrositis? Inflammation of the petrous part of the temporal bone. It is otherwise known as Grady-Negos syndrome. Grady-Negos syndrome. It is characterized by 3 Ds. First is diplopia. Diplopia is because of the involvement of the lateral rectus muscle, because of the involvement of the abducens nerve in the Doral's canal. Where is Doral's canal? Doral's canal is at the tip of the petrous part of the temporal bone, through which the 6th nerve, abducens nerve, passes. Next is discharge. There is a bag of pus inside, so patient continues to have profuse discharge. And because of all this information, the pain will be severe and it is deeply felt. So once you diagnose this condition, then you have to treat the patient with antibiotics, and generally patients need surgery, that is either a cortical mastoidectomy or a modified radical mastoidectomy. If the petrositis is secondary to acute suppurative otitis media, then it's enough if you do a cortical mastectomy or a complete mastectomy. But if the petrositis is because of chronic suppurative otitis media, say because of cholesteatoma, then you must have to do a modified radical mastectomy and try to locate the, generally there will be a fistula from the mastoid bone towards the petrous apex. If you track that fistula track, you have to cure it out and drain it. And facial paralysis is a very, very important complication of mastoiditis. If the infection spreads and if the fallopian canal, bony canal in which the facial nerve lies is dehiscent, patient may complain of facial paralysis. What type of facial paralysis? It is lower motor neuron type of facial paralysis. What are the characteristic features? Absence of frowning of the forehead, and there will be inability to close the eye. It is lag ophthalmos, that is called lag ophthalmos. That means the eye on the involved side will be lagging behind when compared to the normal side. And there is what is known as a Bell's phenomenon. That is, if patient tries to close the eye, the eyeball appears slightly turning upwards. This is called Bell's phenomenon. Bell's phenomenon is a normal phenomenon. It occurs normally in physiological state, but it is not seen because of the closure of the both eyelids. Since the eyelids are lagging behind, Bell's phenomenon is seen. And of course, the obliteration of the nasolabial fold, and there will be deviation of the mouth toward the opposite side. In case of upper neuron facial paralysis, what will happen is the upper face is spared because the upper face has got a bilateral innervation in the internal capsule. Now, next complication is labyrinthitis. Labyrinthitis must be recognized and treated early. Why? If you neglect labyrinthitis, patient may land up in what is known as total sensory neural hearing loss. Not only that, if you neglect even at this stage, patient may go in for other stage, that is, patient may develop meningitis. So how do we recognize? What are the different entities? First and foremost is circumscribed labyrinthitis or paralabyrinthitis. Generally, it is associated with the fistula. Next stage is there will be serous labyrinthitis. That means the labyrinth is filled with exudate. Next stage, that is the third stage, is purulent labyrinthitis. That is, labyrinth is full of pus. It is infiltrated by neutrophils, pus cells. There will be destruction of the cochlea, and there will be what is known as labyrinthitis ossificans. This particular condition should be prevented at all costs, because this condition generally happens because of the labyrinthitis that is secondary to meningitis. Usually children with meningitis will be treated, but it is important to note that meningitis is a speech and hearing emergency in children. If patients are not cared, if the children are not cared about their hearing during the treatment of meningitis, this condition may result. That is, the infection can spread into labyrinth, and the entire labyrinth will be replaced by bone. That is called labyrinthitis ossificans. Very, very difficult to rehabilitate these children once this occurs. Of course, especially the cochlear implantation, which we talk about to rehabilitate children with congenital deafness. It will be very, very difficult to conduct cochlear implantation surgery if labyrinthitis ossificans occurs. Now, how does infection enter the labyrinth? First and foremost is blood spread. That is from the blood into the, as a sepsis anywhere in the body can produce a labyrinthitis. And the fistula or the lateral semicircular canal, which I already mentioned. Once there is a fistula opening over the lateral semicircular canal because of the cholesteatoma, the infection can enter the semicircular canal and the labyrinth. And the infection also can enter through the wall window, especially after stapedectomy. Or the infection can also extend through the cochlear aqueduct. Cochlear aqueduct, it passes into the jugular foramen region. And if there is infection, the infection can also extend, and it may also involve the labyrinth. And the eighth nerve, once it passes from the cerebellopontine angle, it carries a sheath of subarachnoid space along with it. The infection can enter through the subarachnoid spleen into the labyrinth. That is in the retrograde fashion. And infection can also enter through a round window, or infection can also enter the labyrinth by a fracture, preformed fracture. So this is the picture that shows this is the fracture line, and this is the fistula or the lateral semicircular canal. Here is a fistula, and of course a round window. And number 4 is a cochlear aqueduct. This is the cochlear aqueduct. So through cochlear aqueduct also, the infection can spread into the labyrinth. Now, what are the clinical features of labyrinthitis? First and foremost is circumscribed labyrinthitis. It is characterized by vertigo and hearing loss. If you examine the patient complains of giddiness, and you can elicit what is known as a fistula sign. What is fistula sign? If you apply digital pressure or the tragus and occlude the extraurotic canal, then patient starts giddiness, complaining of giddiness. So this is called fistula sign. So how does this happen? Once you occlude the extraurotic canal by positive pressure, then the pressure is carried from the extraurotic canal to the tympanic membrane into the middle ear, because there is a perforation in the tympanic membrane, into the middle ear and into the adytus addentrum, and over the fistula or the lateral semicircular canal, the pressure is carried into the inner ear. That is, inner ear is stimulated and there will be reaction. That is vertigo. And generally there will be conduct deafness that might be having sensorineural hearing loss also. And if it is neglected at this stage, it will go into the next stage, that is called serous labyrinthitis. That is, again, there will be vertigo and nausea and vomiting, and the hearing loss will be more severe than this, and you will find nystagmus. What is nystagmus? Nystagmus is involuntary to and fro movements of the eyeball. So patients start nystagmus, and you generally, in this particular stage of labyrinthitis, the direction of the nystagmus is towards the diseased side. And again, if you neglect at this stage, you will go into this particular severe stage, that is purulent labyrinthitis. There will be severe vomitings, headache, and patient will be very much incapacitated. He cannot move from the bed. There will be nystagmus. Now the nystagmus will be towards the good ear, and patient will be having total deafness. How do we treat? Once again, if it were a case of circumscribed labyrinthitis, generally circumscribed labyrinthitis is a result of chronic suppurative arteries media with cholesteatoma. So once you diagnose it, you do a modified radical mastectomy, identify the fistula, and clear the cholesteatoma near the fistula, and immediately repair the fistula by applying a piece of fascia or the temporalis muscle. If it were a case of serous labyrinthitis or purulent labyrinthitis, it might be because of acute suppurative arteries media or acute exacerbation of chronic suppurative arteries media. You have to admit the patient again, treat him with full antibiotic cover and labyrinthine sedatives. And generally, these people need surgical intervention also. And if it is acute suppurative arteries media, do a liberal myringotomy and drain the exudate or pus, whatever it is. If it is a case of, if the patient doesn't respond and patient is having total deafness, still patient is having symptoms, we may have to do a mastectomy plus what is known as labyrinthectomy. You have to destroy the labyrinth to relieve the symptoms. Thank you.